I've been provided with a one axial CT cut of abdominal window, liver section, contrast enhance aortogram, arterial phase, and I can appreciate there is a slightly ill-defined, heterogeneously, predominantly hyper enhancing mass lesion in the right hypochondria, right liver low, with internal linear branching hypodense area, and the sound there is no any other abnormal foci in the surrounding liver parenchyma. However, there is an either this there is also there is portal vein also. I can see the rounded lesion. Yes, it's portal vein. So there is no any other abnormal pathology I could appreciate. However, there is slightly but just summarizing of my findings. This is enhancing mass lesion in arterial phase. I would like to see the other cuts and sections of CT liver triphasic protocol to differentiate either and further characterize this lesion, and also correlate with the ultrasound images.
Okay. So what we don't have ultrasound images. I'll provide you with triphasic, but first, okay, what would be your differential diagnosis?
This is this is a mixed phase. Can is it clearly aortic arterial? Yes, portovenous phase. Yes. So on the portovenous phase, it is enhancing. And there is no loss of, I can't say there's a loss of contrast on portovenous, as it is still enhancing. And so MATS can be, metastatic lesion can be my DD, but liver carcinoma, because I have no arterial images, so I can't appreciate on this that
this is early portovenous phase. Early portovenous phase of the liver.
So it is enhancing. So this is the carcinoma, liver carcinoma. And as it is in the patient is young, so most likely HCC.
Because he's not young.
Okay, and so also there are no findings of liver cirrhosis or any other. So HCC could, I can clearly rule out the HCC. It's not HCC, but other lung cancers could be fibrolamellar carcinoma, because there is a central hypodense scar element which is not non-enhancing. So this is most probably the fibrolamellar carcinoma.
Okay. Excellent. What is the most common differential diagnosis for fibrolamellar HCC?
There is hepatic FNH, yes. But it will enhance in the delayed phase. So I would like to see the delayed image, either to rule out this.
Yes, sure. I will continue the case with you with the triphasic. But now let's discuss this CT. Excellent, but I thought that you did not know how to summarize this case because it's only single phase. Be ready.
Yes, ma'am. That's why I'm
you can
confused.
See this in practice. This actually came to us as incidental liver lesion on the CT. The patient was doing CT abdomen for I think for another reason, and this mass was incidentally found on the CT with single phase portovenous phase. So always keep your approach simple for liver. First thing, any liver lesion, first word would be background parenchyma. What do you think of the liver? Always, first, is the liver cirrhotic or not cirrhotic? Fatty
non-cirrhotic.
or not fatty? So this is your first word to me. So this is contrast enhanced CT scan of the abdomen at the level of the liver. The background liver is not cirrhotic and not fatty, right? Next, you can see this is it's enhancing, but different types of enhancement. So enhancing can be hypovascular enhancement, such as lymphoma or hypovascular metastasis, or can be hypervascular solid liver lesion, such as FNH, fibrolamellar HCC, neuroendocrine tumor. So it is enhancing, but you need to emphasize on the pattern of enhancement. So its background liver is not cirrhotic, and there is a large hypervascular liver lesion in the right lobe, and we can see this central scar. Next, since you were thinking fibrolamellar HCC, so one of the important positive or negative in fibrolamellar is having central calcification, right? Because having hypervascular liver mass with central scar and calcification favors fibrolamellar HCC. And the pattern of enhancement, do you think it's homogeneous hypervascular or heterogeneous hypervascular?
It's heterogeneous.
Would you favor FNH or fibrolamellar HCC? And if you're not sure, you can ask for next step. From CT, fibrolamellar HCC usually large, heterogeneous, central scar and calcification in the center. And usually the background liver is not cirrhotic. The age group is young as this patient. And if we check the alpha-fetoprotein, it would be normal. Unlike FNH, sometimes FNH can present with this size. And the difference is that FNH usually homogeneous, fibrolamellar HCC heterogeneous. The scar of the FNH will enhance in the delayed phase. Fibrolamellar will not enhance. FNH doesn't have central calcification. Fibrolamellar will have. And next, delayed images as you said. FNH will be iso-intense to the background liver in the delayed phase. Fibrolamellar HCC will show washout most of the time. So any modality, imaging modality that could help you differentiate FNH from fibrolamellar HCC?
Ma'am, MRI.
Excellent. MRI. Any specific contrast agents?
Yes, ma'am. Ma'am, I couldn't remember, but it was, I think,
a hepatocellular agent contrast, Primovest or Eovest?
Yes, ma'am.
Yes. So I can see one of the chat that hemangioma. Yes, hemangioma could be part of the differential diagnosis. However, this size hemangioma, usually you will see peripheral nodular discontinuous enhancement with progressive filling. A flash filling hemangioma that enhances homogeneously from the early arterial phase with this size is not very typical. So it is less likely to be hemangioma, because hemangioma, if it's small, it can be flash filling and homogeneously enhanced. But this size, usually it will have central necrosis rather than scar, and it will show peripheral nodular discontinuous enhancement. And on the delayed phase, it will fill into the center. This is your MRI. So,
yes, ma'am.
Yes. So this is the MRI.
I've been provided with the 4 axial images of MRI abdominal. With the first is T2 axial image, and the other is T1, and third one is also T1, and last is DWI. So here I could appreciate and slightly in increased signal area, slightly ill-defined lobulated margins in the T2 phase, with the central increased signal area, linear area, which is most likely as I have seen in the previous image scar. And on T1, this is iso-intense, slightly hypo to the decrease in signal intensity to the comparing to the parenchyma on T1. And on DWI, it has increase. It shows diffusion restriction.
So this is the in and out of phase, right? So this is T1, as you mentioned. T2, T1 in phase, T1 out of phase, look for intracellular fat, and there is no fat. And you, as you mentioned, it's heterogeneous with central scar and significantly restricting, similar to spleen. We'll come back to it after we finish. So this is the post-contrast.
Okay, on the first image is pre and post contrast, the mass is slightly enhancing with the peripheral enhancement more than the and in central the scar is non-enhancing, and in the lower images the same findings with the this is pure, I think. The lower image, this is in phase and out phase.
No, no. This is T2, in, out, in phase, out of phase, diffusion. This is dry or non-enhanced. This is arterial. And this is
Yes, ma'am.
Yes. So this is dry or without contrast. And this one is arterial, as we can see here, the zebra pattern of enhancement in the spleen. This is protovenous phase, and this is the delayed phase. Okay.
It is enhancing with non-enhancing scar on the arterial phase, and on the protovenous phase, it's still no, okay. On delayed phase, it has been enhanced. So so I could rule out the fibrolamellar carcinoma, and my final diagnosis would be FNH.
Okay. So as we mentioned, we have many signs. So we have the scar, as we said, fibrolamellar. Now the main cases for differentiating, is it FNH, benign, leave alone lesion, or is it fibrolamellar HCC? We said FNH, the scar is enhanced in the delayed phase. Yes, agree. How about the other features? Would FNH show heterogeneous T2 signal intensity? Would FNH show significant diffusion restriction similar to spleen?
No, ma'am.
So FNH, typically, it's very subtle. ISO or slightly bright on T2, which is not seen in this case. ISO on T1 or slightly dark, not seen in this case. Usually, it can be seen as bright on diffusion on the low B value. But as you go on the high B value, it should not restrict as this. See, it's similar to the spleen. It's significantly restricting, indicating it's a hypercellular lesion. Coming back to the post-contrast, it's low. Agree, the scar enhances in the delayed phase. However, if you see the other findings, the lesion is heterogeneously enhancing in arterial, And we mentioned that FNH usually it's homogeneous hypervascular.
Yes, ma'am.
Central scar. This is heterogeneous. And on the delayed phase, if you compare the lesion to the background liver, it's not iso as FNH. Actually, it's washing out. It's darker than the adjacent parenchyma, right?
Yes, ma'am.
So the lesion is washing out.
Okay. So, ma'am, only scar is not a specific sign. We have to look for the other reason. Okay, okay, ma'am. Thank you.
And if someone argues with you, is it FNH? Is it fibrolamellar? We mentioned just now a confirmatory type of contrast.
Ma'am, PAMS, MRI, HCC, ma'am, isovasic, permeous. Yes, ma'am.
Permeous. So
yes, ma'am.
These are the images. Do you know how can we tell that this is permeous? Without saying, if I didn't tell you, I just provided these images to you. How would you know that these are eovist or a hepatocellular agent?
Ma'am, because it's only enhancing the liver parenchyma and not.
Excellent. Excellent.
Yes, ma'am.
So, if I brought you these images without saying, you can readily tell me that these are 15 or 20 minutes delayed Premovist contrast or eovist or any hepatocellular agent. What is the idea of Premovist or eovist? It's a hepatocellular agent. So it's a type of contrast that is taken up by a hepatocyte. So yes, any cell that has hepatocyte will take this contrast. How we know? We will see that the liver lights up in the study, as we can see here. So you see the liver is lighting up. This is coronal, this is axial. The other hint is look for contrast within the collecting system. Within the biliary system. Because if it's taken up by hepatocyte, then eventually it will be excreted into the biliary system. And we will see it in the bile duct and in the gallbladder. So, and yes, if the lesion is FNH, it should?
Ma'am, it should enhance.
Yes. So if it is FNH, then it would enhance in the Premovist, or it will have uptake for the contrast. However, if it is HCC, it will not. So what do you think the final diagnosis?
Ma'am, fibrolamellar hepatocellular carcinoma.
Excellent. And this was a fibrolamellar hepatocellular carcinoma proved by surgery. One last thing, from the initial CT, once you have an incidental hypervascular liver lesion, you can always rely on the ACR guidelines. They have a white paper on how to manage incidental liver lesions. So if your liver lesion is more than 1.5 centimeter, then we have to, if it's typically benign, very typical characteristic benign, then okay. But if it's not, then we have to do MRI to characterize this lesion. Okay? So excellent. This is just an image as I wanted to show you. This is Premovist, 15 minutes or 20 minutes delayed. As you can see, the liver lights up, and this is the difference. This is FNH taking up the hepatocellular agent, enhancing, and this is the fibrolamellar HCC is not taking the contrast.
Ma'am, can I ask one question?
Yes, sure.
Ma'am, is it this because FNH contains the normal hepatocytes and hepatocellular carcinoma didn't?
Yes. So focal nodular hyperplasia by itself, it's a focal nodular hyperplasia. So it's a hepatocyte nodule. It's just a normal liver cell that's got into a hyperplasia. So it's originally, it is a hepatocyte. So it always take up Premovist or any hepatocellular agent. For HCC, well, the general rule say that HCC doesn't take up Premovist or eovist. However, one pitfall is that if the HCC is very well differentiated, or if it's early HCC, meaning that, as we know, the cycle of HCC, it's a low-grade dysplastic nodule, then goes into a high-grade dysplastic nodule, then low-grade HCC, and then high-grade HCC. So during this evolution of HCC, we are transforming from a normal hepatocyte into dysplasia into cancer. If we give Primovyst 10%, 10 to 15% of HCC, we scan them with Primovyst, and they are very well differentiated or early. So they still have a hepatocyte in them. These lesions might show up uptake or enhance in the Primovyst. However, you can rely on the other parameters. So you can rely on the T2 signal intensity, diffusion weighted images, if they are washing out or not on the delayed phase. I hope I answered your question.
Yes, ma'am. Thank you so much, ma'am. I've very nicely and very clearly elaborated, ma'am, this case.
There is a question regarding this case, ma'am.
Yes.
What about the T2 hyperintense scar? And why is the scar showing delays enhancement?
So, as we know, not every case read the book classically. So they say that the scar in fibrolamellar HCC is actually a fibrous scar. So fibrous scar still might enhance in the delayed. So it's not always seen. We always say that if this FNH scar enhances in the delayed phase, fibrolamellar scar typically not enhance, but not necessarily. We always have certain percentage of variant pattern. One of them is that fibrolamellar HCC, the type of scar is fibrous scar, and in small percentage, it might show enhancement. And there has been a lot of studies in the studying the difference between FNH and fibrolamellar HCC, and what sign can we rely on. And the scar was one of the poor indicators. So we should not rely on the enhancement of the scar. We should rely on the other parameters. And eventually we should evaluate all the features. So as we mentioned, we have the scar to assess. We have the homogeneity of enhancement, if it's homogeneous or heterogeneous. We have the signal intensity on T2 and T1. If it's heterogeneous, very bright, or if it's iso to slightly bright. We have washout. And if we are not sure if the lesion is showing mixed features of these, then we can always rely on Primovyst. So in case of fibrolamellar HCC, Primovyst is excellent, and it's very rare, extremely rare, having fibrolamellar HCC showing uptake in Primovyst. And even if they did, it won't show avid uptake as we see in the FNH like this. Even if it is a pitfall and it is fibrolamellar HCC, and we would see maybe subtle areas of enhancement, but definitely it's easily differentiates between fibrolamellar HCC and FNH. So just to confirm, because this is a very important point, FNH, typically it is homogeneous hypervascular. Central scar typically enhances in the delayed phase, not necessarily. Iso on T1 and T2, slightly bright on diffusion. It is homogeneous hypervascular, fade away in the delayed phase. Fibrolamellar HCC, heterogeneous, large, central calcification and scar, not necessarily enhancement pattern is characteristic. In the post-contrast, it will show heterogeneous arterial enhancement, and it might show washout in the delayed phase. And finally, Primovyst. If it is dark on Primovyst, it's fibrolamellar HCC. If it is bright on Primovyst, then it is FNH.
It was a very interesting case, ma'am, and the teaching points were excellent.